Okay, so now we're going to talk about interpreting anthropometric measures, and the measure that we're going to use is the most common one, which is body weight. Now in this example, we've got an individual who then hops on a set of scales, and this can be done in a hospital or a clinic environment. You'll have your own body weight measures that you take from time to time. So what are we actually interested in terms of body weight? We need to appreciate that you get one number, but the number is made up of lots of different components. And in particular, when we're measuring someone's body weight, one of the key elements that we're trying to interpret, just give me a second while I fix my computer here, is the protein component and the water component. They are commonly some of the elements that we might be interested in looking at from a clinical population. From a broadly healthy chronic disease type population, obviously we're interested in changes in body fat as well. But from an acute perspective, it's your protein component and your water component that's probably going to have the greatest potential influence on what's happening to somebody's nutritional status within a hospitalized context. So put someone on the scales and they weigh a certain weight, but there's a whole range of other factors that may influence what happens to somebody's weight in a day. They're going to eat food, they're going to go to the toilet, they're going to be potentially wearing different clothes, they may have showered, and if you've got long hair that and long wet hair can hold water, and you'd be quite surprised as to how much water can actually be held in that. So how much do these things vary somebody's weight on a day-to-day basis? Well, in terms of a hospitalised population, we've actually done some work in that area. Here's a really nice study published a number of years ago looking at short-term body weight fluctuations in a group of hospitalised individuals. Now these individuals were in a rehab unit. And so a rehab unit is less, I guess, intensively medically managed individuals. So you rarely see things like IV fluids being delivered to these individuals. They can often eat quite well. They might be going through rehabilitation type programs. And these particular individuals were also identified as not having any renal impairment. And that's important because obviously if you've got renal impairment, the likelihood of you being able to excrete or retain fluid and seeing larger fluid shifts goes up. So these people had normal renal function. There were 10 of them, and they were in a hospital-based long-term rehab ward. Now for 3 consecutive days, between the hours of 7 a.m. and 4 p.m, on the hour, they were weighed, and they were weighed with the same scales by the same person. Now, it didn't matter what the person was wearing, what the person had eaten, whether they'd been in the toilet or not. This study was purely about, well, to what extent does being in a hospital environment influence fluctuations in weight? And so for 3 consecutive days, they had these hourly weight measures between sort of normal business hours. And this is what they found. And really the key point here is on the right-hand side, that we see large potential percentage body weight fluctuations in a number of these individuals. So if we have a look at the right-hand column, we have 4 of these 10 individuals who had more than 2% body weight fluctuation within the one day. So these are, as I said, healthy, otherwise normal individuals who are seeing their body weight change substantially as a consequence of just day-to-day normal fluctuations. And so that's very important to be aware of when you're dealing with patients that you might see whose weight change in a hospital environment. It could be that you're seeing a change in fluid. It could be that you're seeing a change in their lean body mass. But equally, it could be just the normal fluctuation that you see from one day to the next. Here's the average values. And clearly you can see hopefully from this graph that we have a large amount of fluctuation that's occurring from the start of the day, the 7 a.m. period, right through until the 4 p.m. trial. And in general, during this period of time, people's weight are steadily increasing. And so if you wanted to take their lowest weight, you would come in the first part of the day. If you wanted to be the most consistent that you possibly can, you'd come at the same time of the day, noting that the later you come in the day, the heavier the person is likely to be. But if you have a look at the standard deviations here, we're not seeing huge variations at one time of the day or the other. So what it would appear is that it's critically important to weigh this individual at preferentially the same time in the day, because you're introducing another form of variance that you can potentially account for. And that's something as simple as body weight. And that's in the context of people whose weight from a fluid perspective is not changing. Now, outside of that environment, where you do have people with renal impairment, or you've got people with IV fluids hanging, or large fluid losses because they're having paracenteses, or they've got edema, or a range of other fluid loss explanations, it's likely to be even larger than that. So that's just something to be mindful of. Okay, so what we want to do now is just quickly run through the techniques for measuring a range of these very common parameters. So for things like weight, we want the person's bladder, where possible, to be empty, preferably before consuming meals, preferably first thing in the day if we can. No shoes, light clothing. Do they need to be nude? No, they don't. But the lighter the clothing, the minimal nature of clothing, obviously you're removing one of those random errors or minimizing it. Scales being placed on a hard, flat surface so that they work properly. That the scales are zero, that they're tared before the person hops onto the scales. Subjects should stand in the center of the platform, looking straight ahead, try and avoid wobbling or being on the edge of the scales. Common things that we might see might be things like the use of chair scales in hospitals, making sure people's feet are up on the stirrups that hold their feet, rather than having their feet on the floor, which will obviously change their weight quite considerably, weighing to roughly 100 odd grams, and noting any presence of fluid accumulation and the time of the day, so that the next person who measures may be able to factor some of that change of day in. So how do we interpret that? Well, weight change over time, you might compare, and the key values that we often look for are 1 versus 6 months ago, and looking at that as a percentage body weight change. You may look at it as a weight to height, as in the body mass index, which we'll talk about in a minute, or interpreting weight being in a very cautious manner if you've got nothing else to go on. So a single weight without a great deal of other clinical information doesn't give you a great deal, because of the multi-natured component of what the weight is being made up from. Here we have some common problems or errors. So patients wearing heavy clothing and some proposed solutions. I don't need to read these, but subjects who are anxious, well, one of the key things that you need to consider is, does the person actually need to be weighed? And you'll get far more from your client coming back to see you, because you created an environment which was comfortable and lowered the anxiety level, than putting them on the scale so that you can get your data point. So particularly when you're developing rapport with patients, there's absolutely no problem at all in considering an anthropometric measure and then choosing not to do it because it creates too much anxiety in your patient. And the scale's not calibrated, or the floor is soft and things like that. So being able to calibrate scales and manage the measurement is critically important. In terms of height, we usually use a stadiometer, a freestanding stadiometer. We ask people to remove their shoes and socks, standing with their head in what we call a Frankfurt plane. So I'll show you what the Frankfurt plane is, but basically you can see a small diagram here. I don't know if I can bring my cursor on. I'm struggling to bring the cursor onto the screen here for a minute for some reason. I'll see if I can do it at this point. Not well. Let me try this one. Here we go. So this is the Frankfurt plane here. And basically what we're looking for is the lower edge of the orbital rim. So the lower edge of your bone being aligned with the middle point of your ear, so that the person's not tilted forward with their head and they're not looking up, that their head's in a neutral horizontal position. Feet together, weight evenly distributed, heels, buttocks and shoulder blades in contact with the back surface, arms hanging loosely. We do ask them to take a deep breath and stand tall. And there's a small video here, I'll give you the link for the video, which talks about potentially supporting a person's neck while they breathe in. I would only do that under sort of more controlled or research type environments if you really wanted to get a precise measure of height. But for the most part, getting them to stand nice and tall, breathe in, expand their lungs, you'll maximize their height. And obviously, we would try and measure someone's height if we can in the morning, because they'll be their tallest in the morning, and then throughout the day they'll go through some vertebral disc compression, so you will lose height in a individual throughout the day. In terms of correct methods for age and height, we adjust height for people who are young, particularly around premature birth, so that we work on their expected age based on their gestation period rather than when they were born. So for instance, if you've got a premature baby, you would be basing their height on their age at conception rather than their age at birth, to account for the fact that they haven't spent as much time developing in the womb as another child. So, and the same with people of very short stature. Headwear, footwear, clothing, and you need to make cultural allowances for individuals who may have headwear or footwear, clothing that's appropriate, and practicing your correct technique around explaining to patients what you'll be doing, getting people's head in the Frankfurt plane and what have you. We'll give you some practice at that in the tutorial. Body mass index, I imagine most people are familiar with body mass index, which is just the weight divided by height in meters squared to give you a value. If you've never heard of body mass index, here's the calculation. Do your own. I would encourage you to know not only how to calculate body mass index, but also be aware of the classifications of weight by BMI. So if somebody has a BMI of less than 18.5, we consider them underweight. They have a low risk of comorbidities, but they may present with other clinical problems. Normal range is between 18.5 and 24.9. Overweight is considered greater than 25. Pre-obese in terms of overweight is 25 to 29.9. And then you've got three categories of obesity, 1, 2, and 3, based on an increasing BMI incidence by 5 units. And you're moving from increased to very severe risk of comorbidities. So they're the cutoffs for BMI. Problems with BMI, well, it's weight for height. So you've got the problems associated with weight not necessarily being reflective of body composition. So the mass doesn't give you the breakdown of body fat to muscle. You've also got factors such as the age, family history, gender, ethnicity, height loss due to aging. There's a range of issues there. So we would encourage you to never use BMI in isolation, but consider other anthropometric measures if you can, like their body fat level, their lean mass level, and or similar. It's not suitable for use on pregnant and lactating women, children and adolescents less than 18 years, although there are BMI child growth charts that you can use. So you wouldn't use the categories as defined in the previous slide on children or adolescents. You would use the BMI growth charts. And people who are short or very tall may have a disproportionate BMI just based on their height change. So we suggest that you use it in caution in environments where people are highly muscularized, high performance athletes, elderly individuals, and ethnically diverse groups whose populations may not be well classified in those criteria. If we look at BMI and mortality, it's what we call a J-shaped curve, which means that when your BMI is very, very low, you have a slight increase in mortality. So right down on this far left-hand side here, you have a slight increase in mortality. But between the 20 to 25, even up towards 30, we're starting to see mortality increase, and then it really starts to exponentially increase after 30. So what we have on the right-hand side here are some confidence limits based on those values as well. And you can see that the health outcomes diversify more broadly when you're up in the high BMI ranges. Clearly you've got an increased risk, but the outcomes vary considerably as well. And you can also then break that down based on other criteria as well. So if you're, for instance, aged 60 plus and your BMI is low, then you're at increased risk relative to overall individuals who have a very low BMI. And that, obviously then as an elderly person, you have greater risk of a whole range of conditions. And effectively what that's saying is you've got less nutritional reserve to be able to withstand a compromised health episode, and your mortality risk goes up. We have a range of those factors compared to sort of the overall value here in a range of other factors like whether the person smoked or never smoked and so on. So this data can be broken down and pulled apart depending on risk factors. Waist circumference, there's no universally accepted site. It depends on the individual. Normally what we do is we look for the natural narrowing or the narrowest point when viewed from the front between the bottom of the ribs and the iliac crest, which is the top of the hip. If we can't find a natural narrowing, then we might look at just measuring at the belly button, the umbilicus level, particularly in an individual who's overweight or obese. The key here is to have a repeatable measure so that you're coming back and taking serial measures on an individual at the same site. The key elements here, the person needs to stand tall, their abdomen needs to be relaxed, their arms have got to be by their side, their feet have got to be together. We need a tape that's parallel to the floor, and that when you put the tape around the individual, the tape's resting on the skin and it's not compressing the skin, so it's not pulling the skin in. But you're just allowing as much of the tape to contact the skin as you can. And you do that measure when viewed from the front. And we have various categories for risk for men and women. So we have an at-risk and then a very high-risk category. And you can see the values there, 94 and 102 for men in terms of increasing risk. That's greater than circumference. And then women, it's 80 and 88 centimetres. So once you go above those levels, you move from at-risk. So anything less than 80 is not at risk, but 80 or above is at risk, and then above 88 is high risk. And the waist circumference measure is a really good measure. It's highly correlated with risk of chronic disease. Abdominal obesity is known to be a good predictor of cardiovascular disease risk. Okay, so here's some examples here. So you can see in the top figure here, we've got a lot of compression, and the person's taking the measure themselves, which will usually change their posture a little bit. Here we have a natural narrowing, the tape sitting comfortably on the skin. It's being viewed from the front. This individual has gone for the natural narrowest point. This individual here has gone for the umbilicus. So the key here is to make sure that whatever measure you're taking, you're noting it so that it can be measured again in the future. And then there's a whole range of common problems. I won't read these out, but probably one of the key things, as I said, is keeping the person's feet together, keeping them talking, which will allow them to relax their waist in time. You can't hold your waist in forever, so making the person relax, breathing normally can see you take a waist circumference measure more accurately. Hips, no shoes, light clothing. Again, feet have got to be by their feet together. and we use what's known as the greatest posterior protuberance, which when viewed from the side, your hip measure is as far back or posterior a point that you can see when viewed from the side. So that's considered the hip circumference measure taken horizontally at that point. So again, we'll go through and show you that in the tutorial. And we have our common problems and errors listed out again. Again, I don't need to go through these. You can have a read through them. We can then take those two measures and do a waist to hip circumference ratio, which is just one value divided by the other, obviously. And there are some waist-hip ratio values or examples here. The use of the waist-hip ratio has risen in recognition for its relationship to central obesity. So the traditional male apple shape, as opposed to the female gynoid shape or pear shape, that apple shape where the person's carrying more abdominal fat rather than fat more down at the hip region is considered to put the person at greater cardiovascular risk. So the waist-hip ratio can give you a little bit of that proportion between whether they're carrying their weight higher on their body or slightly lower on their body, and being lower on the body is preferential. And here's the waist-hip ratio values for risk for men and women. So once it goes up above 1 for men, or above 0.85 for women, we're starting to see a greater risk associated with that body fat proportion being higher on the body. And the reason it's different for men and women, as I said, is that women typically have that pear shape. So if they need less of a change in their waist-hip ratio, or less of a shift of one to the other before it's considered an increased risk. One of the last measures, mid-upper arm circumference. It's the midpoint of the upper arm between the acromion process and the radialis. I'll show you how to do this in the tutorial. Find the location when the arm is bent at 90 degrees. And again, you use non-stretchy tape around the arm, no compression of the skin, measured to the nearest millimetre. The reason that we're interested in the mid-upper arm circumference is that it can be used then if you also have the tricep skin fold to determine how much muscle area and muscle circumference that we have. So with the one area of the arm circumference and the tricep skin fold, you can get a measure of the total area and the fat area, and then by deduction you can work out how much muscle is there. And so that's what the mid-upper arm muscle circumference and the mid-upper arm cross-sectional area are measures of. And so there's some equations there which we will show you in the tutorial. Which obviously means that we need to be also able to measure the tricep skin fold. And the tricep skin fold is the most common single skin fold that we'll take. So we'll go through in the tutorial and show you how to measure this, so you can actually pick up the skin and measure this one reliably, so that you're improving your technique in this space. But basically, it's the midpoint of the upper arm. So similar to where you take the circumference around for the mid-upper arm circumference, but it's the point on the back of the arm, and we make a measure, and you pick that area up and you put the skin fold calipers 2 centimeters away from where you pick up. So you actually pick up the point that we identify, but you put the calipers just below that, and we'll show you all of that in the tutorial workshop, which will come up in the next few days after you've seen this video. Basically, it's giving you an indication of subcutaneous fat, and from there we can compare that to average values. In terms of error, there are 2 assumptions broadly with skin folding. That is that the thickness of the subcutaneous fat reflects a constant proportion of total body fat, and so that's an assumption. And that the skin fold site selected represents the average thickness for the entire subcutaneous tissue. So we've got an assumption that the tricep skin fold is reflective of other skin fold sites, and that the skin fold, or the subcutaneous fat, is reflective of the total body fat. And it says here neither are true. In fact, the relationship between subcutaneous and internal fat is nonlinear and varies with body weight and age. In lean individuals have less subcutaneous fat proportion than obese also for sex and race. So there's some errors there, but it's non-invasive, it's quick, and if done using the correct technique, it's reasonably reliable. So some forms of error that we see in skin folding: parallax error, which is basically when the assessor bends down to read the caliper and they're not reading the caliper correctly. Intra-examiner error is due to inexperience, where you're not picking up the skin fold site, or you're doing different things subtly every time you take a measure. And then we have some inter-examiner error, which is usually larger, which is when you would be compared to me or some other person who's taking the measure. So what we really want you to do at this stage is to have no parallax error. So we'll show you the technique of measuring the calipers, and we would like to see you reducing your intra-examiner error so that when you're doing the measure, you're doing the same thing over and over. Okay. Now, if we've got a body mass and we've got some skin folds, looking at the proportion of how these things change, we can then make an interpretation of whether the muscle mass is changing or whether the body fat is changing. And this is a really nice table to illustrate that. On the left-hand side here, we have a change in anthropometric measure being body mass. So if body mass goes up and the skin fold stays stable, remember skin folds are measuring subcutaneous fat, if your mass has gone up and your fat has remained the same, then the interpretation is that your muscle mass has gone up because there's been no change in body fat. So you can use this table to look at that interpretation. Another one might be if the person's body mass increases and their skin folds increase as well. Now, they may have had a gain in muscle mass, but they've definitely had a gain in body fat. Now, we can't tell if that increase in mass is only attributable by way of a gain in fat. There may be some potential gain in muscle mass as well. So use this table as a guide to help you reflect on the values you get for mass and the values that you're getting for skin folding to determine what's actually happening with your client. We also have normative values for anthropometric measures such as skin folds, particularly in a sporting context. How these are used and how they've been interpreted has changed over time. What we look for now is far more information on serial measures from an individual, but you can see here from some of these sports, looking at the skin folds, these are male athletes. If you look at the ranges here, we know that for some sports, such as distance, these are South Australian Sports Institute sprinters. They are all very lean individuals, but the range is very, very small. If we go and have another look at another sport like cricket, you can see here that the skin fold is 77, but the standard deviation is 23 and the range is 52 to 135. So cricket is a sport where you've got lots of different disciplines within the sport: batsmen, bowling, all-rounders, fast bowlers, spin bowlers. And so it's likely to have different body shapes and body types in one team, and also it's a highly skill-based sport. So the anthropometric characteristics are not closely aligned necessarily with performance. So whereas other sports, you have much tighter controls over the range of body mass. So we have those. This is some female data, which you can press pause on and have a look if you're interested. But as I said, we're probably more interested in the serial measures of an individual. And here's some data from an individual who's been to multiple World Championships and Olympic Games. I'll just blow this up so you can see it. Here we have a series of years along the bottom, from 2001 through to 2006. Pink is the sum of 7 skin folds, and blue is the body mass. And so what we're looking for is a understanding of the best proportional sort of body composition of this individual relative to their performance and major competition preparation. So you can see here in 2002, we've seen a slight decrease in body mass, but a large decrease in skin folds where they're going through heavy training. This is an Olympic year, 2002, and then a stabilisation, and we see a competitive period where the body fat goes up and the mass changes subtly before starting competition again. So this sort of information is really useful when you work with an individual, because you can have a look at when they've performed well, maybe when they haven't performed well, perhaps if they've had periods of illness or excessive fatigue. You can plot this over time to determine, well, what is this person's ideal body fat relative to body mass leading into their competition. It really doesn't matter where that fits in with a normative table. What we're interested in is understanding the individual and how they perform. Okay, we might stop there and finish off with some other body composition measures in part 3.